So we're still having a steady stream of joiners, but I guess we'll just get going here. So today's purpose is to gather constructive stakeholder input on how the state can affect positive change for telebehavioral health services. As most of you know, there's a bulletin out there that we are looking to revise. And the purpose of this conversation is to go over OMSAS's responsibilities, some background and definitions, some current regulations that we cannot change, challenges in telehealth, and then have a discussion, questions, open conversation. So that's our plan for the next hour. So, our responsibilities at OMSAS are to promote access. We need to support choice and access to services for beneficiaries that best serve their needs and are delivered in the manner that they prefer. OMSAS licenses a variety of mental health services and supports to ensure health and safety standards are being met for the people who utilize those services. And it's also our responsibility, since these are, MA dollars, responsible for ensuring appropriate verifications are secured to prevent fraudulent MA billing within MA program billing. So those are our responsibilities. And what do we mean by telebehavioral health? What we mean by telebehavioral health is real-time two-way communication, which both parties can hear and see one another. Audio only is real-time two-way communication in which parties can hear each other, but neither party can see each other. Audio only is not permitted service delivery when references to telehealth are made unless audio only is specifically identified. So the federal government defines telebehavioral health in one way and has a separate definition for audio only. So, and I'm going to talk specifically about some issues related to outpatient psychiatric services, because they are a clinic service within our plan and have very strict requirements. So as you know, as providers, outpatient psychiatric services include psychiatric assessment, medication management, individual and group therapy. And when we talk about clinic, there is a designation within the Pennsylvania Medical Assistance State Plan. There are a variety of service areas, like federal designations. One of them is clinic. Within the clinic designation, which is where psychiatric outpatient clinic services requirements are outlined, CMS has very specific requirements for services that are categorized as clinics. So I know folks often think that OMSAS has the ability to make decisions, and we do have the ability to do waivers for some things, but we also, though, are limited by federal payment regulations for which we have no ability to waive and no ability to ignore. They are absolutely not flexible. I think it's important to recognize that they are not something that we have control over when we talk about the federal regulations. So let's talk about what specifically are in the federal and state regulations. Federal Medicaid payment regulations for clinic services. So they require, folks to follow federal Medicaid payment regulations for clinics, which are located at the citation. But one of the most critical parts of that is is either the provider or the service recipient must be inside the clinic when the service is delivered in order to bill MA. That is not Pennsylvania's rule. That is the federal government's rule, CMS. And we actually met with CMS to ask them if they were considering being flexible about this. And they were very clear. They never were flexible about it, and they're not going to become flexible about it. So it is called the four-wall rule, and it is a clear payment federal regulation that either the provider or the person receiving services, or both, but at least one of them must be inside the clinic. We at OMSAS cannot waive that. If we were to waive it, you could not bill MA. Um, and it is also a federal requirement that the services furnished at the clinic shall be under the supervision of a physician. So we're going to talk a little bit about our regs in a second, the 50% APP and the 50% psychiatrist, but that's Pennsylvania specific. The federal regulations is that the director, so the sort of the clinical director who provides kind of clinical oversight, has to be a physician. And once again, as I said, there's no possibility to transform a clinic service into 100% telehealth service where both the recipient and the practitioner can be located outside of the clinic building. As I said, we did have a conversation and attempt to evaluate that with CMS. So then we're going to talk about Act 76 of 2022 supersedes the regulations contained in 55 PA Code 5200.3 definition. And so this is important because it's confusing, and it's been confusing even for me. As many of you know, I'm newer to this role. Our regulations say one thing, and Act 76 of 2022 says something else. So, and most, it permits both audio only and audio telebehavioral health. Our regulations prohibit audio only, but Act 76 of 2022 permits audio only. But it doesn't specify to what degree. We're going to talk about that in a little bit. But it obviously does not allow voicemail, electronic emails, or faxes, or instant messaging to be considered part of a therapeutic service. Next slide. So this is, I've told you already that the federal requirement is that the clinic, the clinic's oversight is provided by a physician. Our current regulations include that at least 50% of the treatment staff providing psychotherapy services shall be mental health professionals. A psychiatric outpatient clinic is required to have 2 hours of psych time per week for each FTE of a mental health professional and mental health worker providing clinical services. And the psychiatrist must provide 50% of the required psych time at the psychiatric outpatient clinic. And the other 50% may be, and the other 50% may be provided by the APP. I think, given that providers speak to each other, and some of you are connected to an association, that you probably know that the most common waiver we have been issuing at OMSAS is to allow the advanced practice professional to do the in-person psych time and the psychiatrist to do their time via telehealth. This is an example of what we can waive. The federal regulations do not require this 50% being a psychiatrist and 50% being an APP. And so, or where they, that they be in the clinic, which one is in the clinic. So this is an example of something within all of this that we had the ability to waive, and we have been waiving. Next slide now. So, this is also from Act 76 of 2022, required psych time may be provided in person or by the use of telebehavioral health by the psychiatrist as specified by our regulations. And advanced practice professionals may also provide a portion of the psych time as defined by our regulations, which is what I just cited. And this is what was added. This gave us, the second bullet gave us that ability to do that waiver that I've talked about here. But it does definitely seem to be a transition in the field where there is more of a need to have the APP be the in-person provider. Okay, next slide. So here's just so as we're thinking about the challenges in telebehavioral health, because we are looking to do a new bulletin, but instead of just writing it and releasing it, we're having these conversations. We talked this morning before this meeting with the BIMCOs, the primary contractors in the counties, having this conversation with providers, and this afternoon we're having a conversation with families and peers. We know there are multiple layers of regulation and the rigidity of the federal government to entertain certain challenges. Certain changes, we can't do anything about that. We also are keeping in mind the requirements for payment and staffing are different based on the service type. We're trying to figure out a balance between antiquated pre-COVID practices and then sort of COVID and now where we are, and kind of since the public health emergency has ended and our ability to just waive lots of things has disappeared. And we want to protect the health and safety of the folks who utilize our services while ensuring that they have choice. And we also are mindful that some folks who access services don't have access to or struggle to utilize, audiovisual devices, broadband, cellular service can be spotty. We are a very large and rural state. So those are just some challenges as we think about what should be in our next and hopefully will stand for quite a while telehealth bulletin. Next slide. So this is where I'm going to stop talking and I'm going to ask, once again, if everyone stays muted until it's your turn to go, but if you have thoughts about what type of services, do you think service type should define what services can be delivered telehealth? Lower acuity services, higher percentage of telehealth versus high acuity service. And do you think service type should define? So what are you licensed as? So those are, what service type, what percentage? So should some services not be able to have any telehealth and other services be permitted to be telehealth? And then what percentage? And then, Hillary, can we just go forward to the other questions and then we'll back up just so everyone sees all the questions. The other questions we have are what services should or should not be permitted to be delivered via audio only? And what obligation should a provider have if a recipient needs to be seen in person because of a personal decision, increased acuity and need, decompensating, or they're no longer able to access telehealth? So these 4 questions, these 2, and then we can go back again, Hillary. And then these 2 are really what we would like to hear your feedback from, keeping in mind that we haven't written we don't have a telehealth bulletin written. We are weighing out all of these factors in our mind and just wanted to have a conversation. So does anybody have anything that they would like to, nobody's raised their hand. So does anyone have anything that they would like to? Great. Dawn, you want to go first here?
Hi there, I'm Dawn Ziegler from Geisinger. A lot of our service areas are in mental health provider shortage areas. And so telehealth has been a way for us to bring care that just the people just aren't there to provide care. So I would struggle a little bit with a threshold if there aren't in-person options. Obviously, we want to do workforce development. We're actually building out a psychiatry program where folks can get medical school for free, working on fellowship and training programs. But I just think we have to be realistic that a lot of our service areas in provider shortage areas. So just would ask for consideration for that.
So my question for you is, and this is a question, but so what I hear you saying is because of workforce shortages, the individual receiving the service doesn't have a choice.
Well, no, that's not what I'm saying. What I'm saying is there's additional capacity we can build into our communities with telehealth, and our goal is to offer both. But if we limit the amount of telehealth, that's literally going to limit the amount of patients we can serve.
Okay.
This is Catherine DeStefano. As a provider, speaking to that, I can't imagine at this point, telehealth has created an extensive amount of access. I believe that, as for should people be able to be seen entirely telehealth? No, we already started implementing as of last year. I think they had said something about the federal regulations, but all of the staff were required to have their clients come in at least one time. Because I think that and none of our intakes have actually ever been done without seeing the person. They don't have to come in person, but we had them get a video because we have some elderly population that they would have no services if they were required, 1, to come every time, and 2, if we had to use video. Because honestly, I've shown my 77-year-old how to hit the FaceTime button at least 4 or 5 times as we practice when she's in person, and she's never hitting that button. so I can at least get her to answer the phone. So I think that it's a matter of like I believe the burden is on the providers to teach our clients how to utilize that service, also set up the expectations and boundaries to create the same kind of environment. Like, I mean, you can only do so much, but I mean, it is our duty to like kind of create at least as much education on how to have quality services. I mean, I use telephone communication with several of my clients that I've known for a long time, and sometimes it works better. I mean, I can either have a 15-minute like barely valuable like video session because the rest of the hour is spent with, oh, can you hear me or not. So we do what works best for the client. We've been open since the beginning of since COVID happened. I mean, we never went completely we let people come from the beginning. It was just like different percentages, 5% at first, because we were the only place anybody went. So we tried to keep it open for other people. But I do think that we would be doing a disservice to a lot of people in places if we didn't at least create the access, because now they've had it. I do think, though, it needs to not be a lazy methodology of delivery. And that's a matter of I think that's what the question is why are providers doing it? Is it because it's easier for them, or is it because it's better for the clients? I mean, I know the rule here is it's sometimes we have to work with our clients, and we had work done at the office just 2 weeks ago, and we would have been able to do therapy at all. So we had made the plan and worked with clients. Some clients chose to change their appointments because they didn't want to do that, and that's fine. And then other clients, it allowed them to have continuity of care and services went uninterrupted. Same thing with snow. All my providers have a backup plan for when it snows, and clients who don't want to come, who want to wait, they will rearrange that. They move some of their clients that are okay to do telehealth. And then it just kind of helps with seamless incorporation of day-to-day life circumstances, and allows for better continuity, in my opinion.
Okay, thank you, Catherine. The next is Marie Kearns.
There we go. Okay. Yeah, I think when you ask what services should be delivered via telehealth, I think that what has really helped is having that option, even though some of the higher acuity, I think, should be primarily in person. But having that ability to do telehealth, for example, in family-based services, we do primarily, in person, but occasionally we have family members that cannot come to a session, maybe as parents who are split up or whatever. Being able to use telehealth is something that allows us to broaden our services. Instead of having a displaced parent not be able to participate, we actually can now. We have kids who are in RTFs who are in Pittsburgh area, and we're in Philadelphia. So we can do routine, regular visits with that child before they return home and with their family on a telehealth platform. So I think that limiting it to solely outpatient type of service is, understandable, but I think that there's other levels of care that should be able to, at least by some percentage, be allowed to have telehealth services. In regards to audio only, we've been very strict about audio only has to be by exception. They have to document that the person can benefit from an audio only session. And everything needs to be done to assist that person to participate in a video session. And if they can't, then that's fine. But we do put the onus on our practitioners to really make every effort to it not be audio only. You miss so much when you can't see the person. So we do put a lot of parameters around that. Thank you.
Great, thank you. Kaylee, number 2. You're muted.
Okay, there we go. Piggybacking a little bit off of what other people have said, I agree there needs to be some sort of mix with very specific, parameters. I definitely think that people, although it's a little more convenient with, the higher acuity, I think they should be seen at least to some degree in person, unless there is, exceptions like people have mentioned, like a snowstorm or, I think the hard part about that is, how do we regulate and specify this person is acute enough that they must be seen in person. This person is not. This person, it would have to be so specific unless, because it's just so vague if it's just up to the therapist or up to the clinician or, but I definitely think there needs to be some sort of like expectation of like maybe that person needs to be seen monthly in person, or like this frequently in person, while they're in that level of acuity, just so that they can be checked in on, unless that person for some reason is like incapable of doing that.
Great, thank you.
We just had a
Hold on.
We just had a recent.
Hold on.
Sorry.
Ron is next. I'm just trying to maintain the order of all of these folks who have their hands up. So Ron?
Yes, hello. Hi, this is Ron Hanley from Hope Springs. So first of all, let me just say I do not envy your position. You have got a quite a bit to unravel here, but we are very specific as an IOP provider. We do very minimal GOP, but we're very specific to being an IOP provider. And I think your first bullet point really is what we should be drilling down on as providers, and that is the acuity. And the acuity should be defined not based necessarily on the client. If you're a GOP provider and you think the acuity is that great, perhaps they should be in the next level of care, just as we would recommend potentially a PHP. I think that anything above the GOP level, from our experience, from my feedback from all of our counselors, and we as well, just to piggyback on, we never closed our doors to in-person. When COVID was this big scary monster, we allowed our clients to dictate to us what they wanted, and the bulk of our clients still wanted to come and continue coming for services. I think there's a place for telehealth in the community. I just think it really needs to be driven by level of care, with the exception of certain real barriers, whether that be distance, whether that be, and I apologize, there's no way I'm going to remember everybody's name, but I think, the person that was speaking just before me, if you have a family type situation where someone doesn't have access, I think there's a place for it there, but to just paint with a broad brush and say, telehealth should be accessible based on the clinician's judgment is really going down a slippery slope. And I think that it really should be based off of by and large, with certain exceptions, based off of the level of care being provided.
And within that, do you have suggestions or thoughts? I'm be transparent. Doesn't mean it's just what I think. Doesn't mean, like, for me, I think most folks know that I am very invested in the creation of the 24/7, 365 crisis system. So we stop having folks end up in jail or in EDs for very long periods of time. And so for me, mobile crisis should not be a follow-up, could be telehealth, but a mobile crisis. It's a mobile crisis. We want mobile crisis to go, not law enforcement. So that to me should always be an in-person service. If you're 302'd and you're involuntarily placed in a facility, feel like the people serving you should also be in person. Are those along the lines of what you were referring to in terms of?
100%. I mean, but also I think even beyond that, you've got, if you just look at the commercial side of things, we'll just talk to that, or outside of mobile crisis, just what most clinics are doing. You've got your general outpatient, you've got your intensive outpatient, PHP, and then of course inpatient and/or residential. And/or residential or inpatient, obviously, it's not part of the discussion by definition, right? You're not going to do that telehealth. But I mean, you could, I guess technically they could sit in a room and have their provider log on, but
that has happened.
Yeah, which I mean, I would think would be a pretty big no-no. But honestly, I think everything from IOP and above, just based on seeing our patient base over 10 years come through, the amount of times that we have to send someone to crisis, I'm sure there's a way to protocol that through a telehealth visit, but I wouldn't want to be in that mess. I just feel like, if people are meeting the criteria to be in an IOP or a PHP, most of those services should be delivered face-to-face. Yes, there should always be exceptions to every rule. I don't know how you you go down that road, other than some of the obvious things, distance. Again, someone's, the once in a blue moon, the inclement weather type scenario. But to say anything above the general outpatient level can be done 100% telehealth, I think is at a detriment to the clients.
Thanks, Ron. Angela Sinclair?
Hi, thanks. I agree with everything that's been said so far. It does get down to the clinical assessment of the patient, and at higher levels of care should be considered in-person services. But there's always those exceptions that we need to consider. But I do want to go back to the one statement that you made, Jenna, and I think I've seen a few people chat about it, and it's the 4-wall rule, where either the client or the provider has to be in the clinic to provide telehealth services. This is new information to me. I don't remember seeing this in any of the bulletins. So if I'm understanding this correctly, you can't have a provider providing telehealth services from their home to a client in their home?
Not as a psychiatric outpatient clinic. No, you cannot.
As an 08-110.
Yes, psychiatric outpatient clinic. If you are licensed as a psychiatric outpatient clinic, you cannot, it is a clinic. And as a clinic, it is subject to federal payment regulations, and the federal payment regulations are very clear that you cannot, either the recipient or the service provider must be inside the clinic. We met with CMS to ask for flexibility for that, and they said no, but suggested we could explore creating a different service that was not a clinic that had that flexibility.
And can you send me the link, or can you send out the link to where those CMS regulations are that specify that? Because honestly, this is the first time I'm hearing this. And from the chat box, it seems like there's other people too that weren't aware of this.
It's right there.
Okay.
On the screen, you see it? It is, yep.
Okay, so if you're individually enrolled, then that's fine. But if you're part of a clinic, you have to be within the clinic, either the provider or the client.
Right. This is specific, as you see on this slide, for psychiatric outpatient clinics that are licensed as a psychiatric outpatient clinic. This is the federal requirement, Medicaid payment regulation that we cannot waive.
So it leads me to believe what's the advantage of being enrolled as a clinic? That's the discussion we're having. Like, what is the advantage now to being enrolled as a clinic rather than just going out and being individually enrolled as a provider if you're licensed? It seems the only advantage to being a clinic anymore is if you have unlicensed clinicians providing services.
Correct.
Okay, thank you.
Okay, so I was just checking the chat. Who's our next? Trying to go in order of, so Kristen.
So I'm just going to go back and say, I don't think that, and I am in a clinic, so I'm coming from another aspect. I'm an outpatient clinic, so this is very real to me every day. Are my therapists in the building? Can I get a licensed person? And we're seeing that is more and more difficult to obtain a licensed person to be in a clinic because of some of these regulations. So I think one of the benefits, though, that sometimes we overlook is the integrated behavioral health piece, that collaboration of being in the clinic and having a little bit more of an opportunity to match our patients, not just solely with whether or not they're receiving telehealth for one service or not, but are we connecting them, again, patient-driven, patient-centered? Are we making sure that they're connected and aware of the other resources?
Great. Okay, if next after Kristen was Mark.
Thank you. Appreciate this opportunity. I would say for outpatient regulations, I think as a matter of equity for our clients that telehealth, that there would not be a specific ratio or a percent of clients who can receive it. I think it depends on the community. And we have within the organization America that I'm a part of, we have some sites where it is predominantly in that community. Folks come in to the clinic. They're very much an in-person group, and there are others, due to extenuating circumstances, that there's a significant portion of the clientele that utilize telehealth services. But it's been able to provide access to folks who might not otherwise want to access it, especially a younger population, which we've had difficulty engaging historically. Also, minority populations, we found better engagement with it. I would also say that when it comes to recruiting, there's an expectation, at least in the workforce that I've encountered, that there is this ability to do some telehealth. And because it increases show rates, it does make at least outpatient positions more viable for folks. And so I would support on the outpatient level there being flexibility.
So when you say that, knowing that we can't, under psychiatric outpatient clinics, we have no ability to do flexibility, we would have to explore another service modality that was in a different part of the state plan. Is that what I hear you saying you think is of value to explore?
Yes, yes. And Jennifer, I would say that 4 walls rule is applying to outpatient psychiatric clinics. There's Medicare guidance that's sort of gone in the other direction from it. And so I'm going to have to look into it, because I would think that many providers across the state would need that kind of clarity as to just to confirm that that's in fact the case.
Yeah, well, and I will just say, because we, with OMAP, OMSAS and OMAP met with CMS to have this conversation, because they also have different clinics, things that fall under the clinic option if you were to look in the state plan. And they were incredibly clear with us that our option was to come up with something under the rehab option of the state plan, but that clinics were not going to change in terms of requiring one person, the service recipient or the service provider, to be inside the clinic.
Well, could I just ask, is that something that switched when the COVID-19 emergency ended, or it never was allowed?
It was never allowed. They never waived it.
So even during the height of COVID, the expectation was that everybody would be fully staffed in a physical office with folks providing services.
Not from, be clear, not from OMSAS.
No, I know, but
From
by the feds.
Yes.
Okay. Huh. Okay.
Yes. Yeah, that's what's our sort of like, really? So this is one of those, moving forward. So I hear you that another option in another place in the state plan would be something that folks would encourage us to look at. That provided the same service, but not with the CMS same 4 walls rule. Chris, you are next.
Hello, hi, everybody. Thank you for holding this, Jenna. I would say that hearing the feedback about crisis services being provided, telehealth, I do know that there's a lot of telepsychiatry being used to facilitate 302s. The 2-hour window piece is a very challenging aspect to that law, which I don't think we should change. I agree with that. We're suspending someone's civil liberty, so service needs to be provided timely, but that's certainly being done telehealth. And I would think that would be a huge gap in service if it was not available or able to be utilized. Of course, I would say that this is interesting conversation to me, because when we think about 988 and the interventions being provided over 988, what's expected. Now, of course, you can dispatch mobile crisis when needed, of course. But, the goal is to not do that. And some of the numbers out there are upwards of 80% of folks who call 988 can be diverted to a lower level of care through a pretty active telephone interaction, which would include safety planning and connection to services and things of that nature. I really do think that limiting telehealth services just really becomes a challenge for folks in accessing care that's necessary and should be immediate. Now, when we talk about other levels of care, for example, ACT, those providers should certainly be seeing folks face to face as much as they possibly can, but to say that they should never use teleservices to connect with their clients, I just think is short-sighted.
Right, and so here's the question I have with that, Chris, is I don't think anybody disagrees that access is the goal, but how do you ensure that access and individual choice? So with, I've heard some very compelling arguments from talking to ACT team providers that they would like to be able to have at least 10% of engagement with a person in a month be telehealth. Because if the person stops coming to group or something, they have the ability to engage. But then other folks say, well, don't put a percentage on it. But then I've talked to peers who have reached out to me to say, I only wanted to see a therapist at least on camera, and they tell me I had to do audio only. I'm not doing that. I'm not telling someone my whole everything about myself when I can't even see them, and so
I would agree with that wholeheartedly, that if
so it's like this challenge of what's the right, how do we provide the guidance? That's why we're having the conversation,
Sure. Yeah, I'm sorry, I'm from Lenape Valley Foundation. And yes, I agree that if a client is requesting in-person services or face-to-face services, either through a camera or coming in, that should absolutely be available. I don't disagree with that sentiment at all. And that's certainly what we're doing here at Lenape. I guess I'm talking in the other direction.
Yep.
That's
Okay.
all. Thank you.
Thanks, Chris. Aaron, Glenn? Do we still have an Aaron, Glenn?
Sorry, I couldn't get to my mute button.
That's okay. Just want to make sure.
So I would echo a lot of what some other people are saying. I also want to bring in the perspective that while I absolutely agree, whether it's crisis or partial hospitalization, IOP, those higher level of services 100% should be able to happen in person where possible. From the rural perspective, we don't have partial hospitalization in some of our rural areas. We don't have IOP in some of our rural areas, and we don't have a volume to justify just opening those types of services here either. Or otherwise we would, nor could we find the staffing to be able to do it if we wanted to. So I do think in those cases, providing some allowance to be creative, to connect individuals, whether they maybe came into a rural clinic like ours and connected to maybe one of our other sites, that does have partial, where they're still on a site, they're still supported here, but they're able to creatively access that service that otherwise we can't bring here to sustain fully. And, same with crisis, where I will tell you, our crisis team does not do telehealth. They don't prefer to do telehealth. They, really very rarely used it during COVID, only if someone was actually maybe diagnosed with COVID. But with that said, we're also in a condition where we only have enough funding, well, actually not even enough funding to have one person on staff at a time. So we can't send individuals out mobile to somebody's home, one person. We can send them to schools. We can send them to, other areas like that. So I think just making sure that there is some creative allowance in how things are done, because the more finite we make it, we may actually end up hurting individuals in being able to access services that they truly could need, and that providers can be creative in trying to figure out for individuals.
Thanks. Courtney Reed.
Hi there, thank you. Hi, I'm Courtney Reed. I'm the director over at Lower Meridian Counseling and Mobile Services, part of RHD. We are also an ICWIC, so I may be repeating what some others have said, but I think, one of those silver linings of COVID has been that it's breaking down the stigma of behavioral health services, which then is allowing more individuals to ask for services, which is amazing. However, it creates growing wait lists. And I think with the 4-wall rule, it's really going to put a hindrance on our staffing. I think one of the flexibilities, one of those silver line, other thing with COVID has been like, people want work-life balance. People want to be able to have that balance, and including the individuals and families that we work with. And so creating these strains and requirements of someone being in the clinic, specifically for outpatient, I think is a huge hindrance. So I'd be agreeable to the service modality change. However, that would also need to be a conversation with all the other ICWICs within the state of Pennsylvania, if that would even be something that would be allowable.
Okay. And I just want to make sure folks are clear, and I think you were clear in what you said, that, the standing requirements for psychiatric outpatient clinics have always been the requirements for psychiatric outpatient clinics that are dictated by CMS. And so we're trying to figure out if we go forth and create something that has a little bit more flexibility, that is not within the clinic option of the state plan, to try to be responsive to what we hear.
Yeah.
Okay.
Yeah, thanks.
Yep. Cecilia Hollins.
Hi there. Can you hear me?
Yes, we can.
Hi. Yes, my name is Cecilia Hollins. I am the Director of Clinical Programming at the Barber National Institute in Erie, Pennsylvania. I guess I would want to echo what others have said insofar as the acuity of the service level, or I suppose the level of care, being a driving factor in how much telehealth can be provided, although I do think there should be flexibility for extenuating circumstances on the part of the client. But I do want to speak specifically to outpatient telehealth, especially when it comes to the ability to perform audio-only sessions. I believe it was Mark O'Dwyer who mentioned, some consideration of the population that's being served. Our outpatient clinic specifically serves individuals who are active with county probation or state parole. So effective January 1st of this year, we did move to being all in person. Before, we'd been doing a blend of in-person and telehealth. And we are only doing telehealth via audio video when a client has the ability to do that. We have integrated technology within our electronic client record. However, the problem with that for us has been that many of our clients, because of homelessness, lack of technology, any number of things, don't have the ability to have session in that way. So audio only was a huge benefit to our client population. And since we've made this shift, we've seen a pretty sharp decrease in our show rates, which obviously, impacts the sustainability of our program. So I guess I wanted to know if there had been any additional discussion about how to get consent for an audio only session. If verbal consent at any point would be allowed, as it was, in the midst of COVID. Again, just because for our population, that was such a huge benefit.
Good question. It's on my list for us to figure out. Thank you. Laurel Spencer. Currently number 2, should be
Yes.
number 1. Yes.
Yes, hi. I just want to come back to the 4-wall rule just to make a comment. One of the things that has been clear since COVID is that the opportunity to expand the telebehavioral health, previously known as telepsychiatry option, has been closed. What we were told by Local Health Choices was that now that telehealth is available, telepsychiatry / telebehavioral health expansion options would no longer be available. So, currently we're on a waiver. So all of our psychiatry services are through telehealth companies. So coming back to this 4-wall rule, this requires all of our clients to come into the building. But number one, it doesn't, provide any kind of rate enhancement that allows us to have clinic staff available for those clients. And two, it really, again, I'm just going to echo what everybody else is saying, that it really then, eliminates client choice. So we're really forcing people to come in the building. So when you're thinking about the possibility of looking at a non-clinic model, that would be just another thing to think about. Thank you.
Yeah, makes sense. I think it's Carrie. Next, who's?
Yes. Hi, I'm Carrie Parnes, CEO of Philadelphia Mental Health Center. A few of these things have been addressed. I want to add to it, having to do with staffing, access to care, etc. First of all, to find a psychiatrist who's willing to come into the office and sit in the office these days is close to impossible.
Yes.
It's just, no one's doing it anymore. So that's the first piece, to be compliant.
And Carrie, you have heard, I just want to say one thing real fast. I think I said in this call, I had a 9 o'clock with the county. So, that is the waiver I have issued the most, because obviously my role is I do issue the waivers related to regulations. And we have the most common waiver is the flipping of the psychiatry time in person for an APP person, because we have overwhelmingly heard that psychiatrists after COVID are only working from home. And so not all of them, obviously, but the vast majority who work in the community mental health system are. And so we have been approving that waiver without question, that, flip-flopping the
So
time.
we were told by OMSAS that we had to have 50% in office, and we've been working on that, but not very successfully. So you're saying we could apply for a waiver?
Yes.
Okay, great. So that's the first.
Where the
piece.
50% would be the APP and in person, the advanced practice professional, and the psychiatry time, 50% by a psychiatrist would be remotely. Because the act requires.
So one or the other has to be in the office.
Yes.
Is what you're saying. Okay. Secondly, it is very, very hard to find clinicians these days willing to come in the office, to support the great number of people who are now looking for outpatient mental health services. Yes, COVID, less stigma, all these kinds of things, and a lot more people are seeking treatment, and clinicians don't want to come in. So there's that. Lastly, there was a discussion here a few minutes about rural populations. I've always felt, and it has been proven to us, that we have a different kind of scenario inner city where there are barriers to treatment when people have to come in the office. We deal with largely with underserved populations and also with the elderly. It is hard for them to get themselves to an office, get on multiple buses, a subway. They're dragging children, if they have families, all of that. And for them to come in the office as opposed to us serving them in their homes means that I think we'll lose a great number of our clients switching over to this, and people won't be willing to come in, which is a terrible shame. Lastly, I know at PMHC, we require video telehealth unless, again, underserved population, if they don't have a cell phone or a laptop that will support that, or some of our elderly clients are just not able to figure out the technology for a video conference. And in those cases, we would document that and we would allow them to do it by phone. So I just wanted to add those comments.
Thank you. Thanks. I also just at this moment, kind of Don, when we were talking about the advanced practice professionals, I don't know if any of you are close to Drexel, but I was talking to the nurse practitioner program at Drexel, and they were telling me that they had to turn away students who wanted to be psychiatric nurse practitioners because they didn't have enough field placements for them. And I know that, given the challenges we have with psychiatrists being willing to work in community behavioral health services, that, increasing the number of CRNPs that we have access to is quite important. And so I just thought that was an interesting fact in case any of you do have connections there or would like to reach out to Drexel. Rosemary, you're next.
So I would like to respond to what you just said first, then I'll go back to my my question, what I was going to ask before. So I'm Rosemary. I am the owner and founder of Rose Psychiatric Services, and we are a licensed outpatient mental health facility in Malvern. I am also a psychiatric nurse practitioner. So in terms of, most of the schools saying that, they have to turn a lot of NP student because of lack of placement, that's actually not the true fact. The fact is that the state of Pennsylvania continue to deny psych nurse practitioner the ability to practice, the full scope of their, their authority and their education. That's what the issue is. It's not because of that, because even at my practice, being a, one of the first NP-led practice in the state, we spent a lot of money just to, thousands and thousands of dollars to have a psychiatrist just sign to be a collaborating physician, and it's like almost $5,000 a month just to have one psychiatrist now actually in the office just signing to be a collaborating physician so we could have NPs work. So that's where the problem is. So if we really want to go back and find a real solution, we will start with that. There are almost 38 states in the United States of America. I was working in New York, where I work as I didn't need a full practice authority. So I was licensed in the state of New York. I had my own facility and I didn't need collaborating physician. And we were thriving and we were providing services. When I moved to Pennsylvania and wanted to open my facility, it took me almost 2 years of delay because first I couldn't find any psychiatrist who was willing to sign to be a collaborating physician. So there are a lot of NPs, like in my office, every year so many NPs apply for a position there when they get out from school. But I always have to tell them, listen, we can't find any psychiatrists to sign on to be a collaborating physician. So I think this is a very critical piece, of this whole big pie to look into that, because CMPs are qualified. We are primary care providers under the Pennsylvania law. So we should remove all these outdated, biases that prevent us to provide care to people who actually need it. So that would be the first thing that I wanted to say to have that clarification. Yep. I don't know who Drexel gave you that information, but that's not accurate. That's not the reason why. We need to look at what the actual reasons are. Secondly, what I also wanted to talk about, the telehealth, is that I agree with most of what everybody else is saying, right? That, as one of the only few places that provide intensive outpatient for the school age child, our services, we see kids as young as 5 for IOP. And I think, there is such a need for it. Yes, kids at 5, we would not want to do no telehealth for IOP. Right? So even in my facility, we have a requirement that most children has to come in person for us to engage with them. So I think, telehealth has a place, but we also have to be very mindful and careful as to how we utilize that so that we don't do a disservices to, children and, some folks who actually will benefit from coming into the office. Thank you.
Thank you. Okay, so now we're at Laurel Spencer.
Yes, I just want to echo everything Rosemary just said, but add, we are a site that does and has turned away nurse practitioner students because in addition to the whole collaborating rule after they're graduated and licensed is students. We don't have any psychiatrists willing to take on students. They just won't do it. So we can't, we don't have qualified staff to support that process. And yeah, that's it.
Okay, thank you. Anne? I have an Anne who's got their hand up. Who's not, if you're talking, we can't hear you.
Not working? There it is. Okay.
There it is. I hear you now, Anne.
Okay, great, thank you. I just wanted to add, I agreed with everything the last two people said, but another issue that we're having is in our partial hospital programs. You can't use a CRNP in your partial hospital programs, and something needs to be done about that. You know, they do the very
that
same
what's a-
path. I'm
And is
sorry.
that in the I'm sorry, is that in the regs that prohibit
Yes, yes. And they do the very same things that they do in outpatient. They do medication management, they do evaluations, talk with the families. So I don't know what the difference is and why they deny it. And with the unavailability of a regular psychiatrist,
And
all these programs are in jeopardy of closing.
And you do not need to go any further with me. Obviously, I have no magic wand, but I had all 3 of my children with nurse midwives. So I understand the value of APPs, and I will continue to evaluate what I can do to try to within our regulations. I hear you. So I
Thank you,
don't
appreciate that.
need, just so y'all know, I don't need to be convinced of the value of physician's assistants or psychiatric nurse practitioners. I think they're both lovely professionals that we need more of. Beth?
Hi, my name is Beth Ritchie. I run the outpatient programs at Gemma Services in Philadelphia. I've been in outpatient community mental health in Philadelphia for about 18 and a half years. And I just want to give like a wider lens point of view, because a lot of this is focusing on like really small changes that may increase barriers to care. And from what I'm seeing, like the whole field has changed since COVID, and maybe it'll go back someday. We don't know. But overall, like there is such a gap between outpatient level of care and other levels of care. And we're the entry point for everybody most of the time, unless they're in crisis. And we need less barriers to care, not more percentages. And you can do this for that. Like we all definitely want to improve our telehealth services and make sure the kids get the best care possible. But I think we need to be looking at the reality and not just the ideal of a lot of my interns that I'm desperate to get leave and go right to private practice, because you can do that. You can do private pay, private practice. And in the city, it is changing drastically, and it is hard to find staff and it is hard to pay them, and we can't compete. So I really think that the state needs to look at that wider view as well, so that we can make sure that more services aren't closing, because in Philadelphia in the last month alone, 2 outpatient providers have closed, and they sent us a lot of their referrals, and we already had a wait list. So I would implore you to consider reducing the amount of requirements that you have for outpatient, because we're supposed to be the first step.
Yeah, I will say again that the outpatient clinic regulations are others outside of that APP psychiatry division of time, where I've been issuing the waiver that the APP can be, the person does the in-person time. You know, some of those, it is in the clinic. I mean, just 2 seconds. They're in the state plan. There are many categories. The clinic is also, because remember, we're unique in that behavioral health is carved out. So in the clinic, a lot of physical health clinics are in there as well as outpatient psychiatric clinics. And the rehab option is where other services are, like psych rehab, crisis. They're under the rehab option, and they have different federal payment regulations. So when you heard me say earlier in response to one of the questions that we're evaluating options about what a new service modality under the rehab option, it could have more flexibility. We are not the ones with the psych rehab, we are not the one with the psychiatric outpatient clinics that we don't have the same flexibility because of the category of services at the federal level where it's located. So we are evaluating and hearing from you that it's important to think about service that could be 100% telehealth because of some of those challenges, but still ideally pay ideally the same rate, right? Is what I'm hearing from you is what you would like us to do. I want to be clear that the goal of today is a conversation. Is a conversation to kind of level set what is and talk about what should be, instead of just us, we could just write a bulletin and send it out. And, instead the goal is to have this conversation, this dialogue. And, a lot of you have echoed, I do travel across the state a lot and talk to providers and counties and our peer and family organizations. And I've, the advanced practice professional comment I've heard multiple times. I understand the workforce challenges. I will say I was previously the executive director of the Pennsylvania chapter of the National Association of Social Workers. And we've been trying to figure out, could we create something similar to C-Well and C-Web, which is a recruitment for Pennsylvania has 40 accredited schools of social work, second only to New York. And C-Well and C-Web work to recruit social work students into child welfare. Most students don't even know, at least on the social work side, that community mental health services are an option and what the different services are. There's not a class on that. And there's not a recruitment strategy. So we are definitely looking at those kind of issues as well, because I know that workforce is a huge driving factor. So I don't want, I realize that the 4-wall rule is something that is frustrating, not within our control, but we are looking for options. And Hillary, can you go to the last slide? There is an email where I encourage you, if you think about those questions, or if you want to send in anything in writing, please feel free to do so. Obviously, we talked to the provider organizations that, that some of you may belong to. And we will be working I have pages and pages of notes between the two conversations I've had, trying to figure out how we balance ensuring access to client choice, to workforce shortage, and not only react, but how do we try to proactively, work on the workforce issue and modality options, so that some of those strict federal regulations, which we met with them to ask them to waive it, and when we were told nope, then that's when we were told to find other options. So Courtney.
I just wanted to find out if these slides are going to be shared out.
Yeah, the challenge is, yes, but I obviously don't know all of you. I obviously talk to RCPA on a regular basis, but I know all of you are not RCPA members. So I will share them with RCPA, and I will share them. I don't know how else to get them to all of you, because there's, but I will send them to the licensing, the regional directors within OMSAS. So, Leanne, Rich, and the two Scotts.
And if anybody doesn't receive them and they would like to, feel free to email this email account, and we can make sure we get them to you that way as well.
Awesome.
Thank you, Kendra. I was struggling on how I would make that happen.
Sure
I was like,
thing,
I don't
no
know all
worries.
these people. But once again, so here's the address, and then, Hillary, can you go back one slide? Just in case you want to see this question again, related to audio only, or if a person changes their mind and wants to be in person, or the acuity becomes such that it's clear that they should be in person, what do we do then? And then one more slide back, Hillary. Then the other two questions is, should what service type define how much telehealth and what percentage of telehealth, and I obviously have your notes from things that people spoke, but please feel free to, as you think about this more, and let us know your thoughts. It's our goal to try to, we realize that it is a very large state with, that is very unique. Philadelphia is very different than Tioga County, and we are aware that trying to create guidance for such a vastly different state is challenging. But so your perspectives, thoughts, suggestions, creative ideas are all welcomed. And I want to thank you all for spending this time with us. We appreciate it.
Thank you, Jennifer.
Take care, everybody. Have a good day.
Thank you.